It's my pleasure to introduce Gregg Stone, Professor of Medicine at Columbia, Director of their Medical Research and Education. His title is Prevention of ACS and Sudden Cardiac Death Possible, Insights from Prospect. Dr. Stone trained at Johns Hopkins for his medical school, then went to Cornell, New York, and fellowship at Cedars-Sinai, and also fellowship at St. Luke's, and is now at Columbia. Welcome.
Great. Well, thank you. Well, thanks, everybody. I think this will be a pretty interesting topic to go over with the deep thinkers at Duke. And I say that actually respectfully because this is probably, I think, the most interesting project that I've ever worked on. And it kind of may, and I'll say may, redefine how we think about underlying atherosclerosis, coronary artery disease progression, and also it has a lot of implications to future drug development. So I'll be very interested in what you think about this methodology and what its implications are. But the title of this is Prospect, which is Providing Regional Observations to Study Predictors of Events in the Coronary Tree. And these are my disclosures as are relevant to this talk. And this is actually a modified slide set from the late-breaking trial that we presented at TCT. As you'll see, this is actually not a trial. It's actually really a study, and it's actually just an observational database, but it's a very carefully controlled observational registry. And I'm proud to say that actually of 110 late-breaking trials that were submitted to TCT, this was actually the highest rated, which was fascinating because it's not a randomized trial. So the background for this study was to try to understand if we could possibly prophylactically predict patients who were at risk for sudden cardiac death or myocardial infarction. And most cases of sudden death and MI are believed to arise from plaque rupture with sudden thrombotic coronary occlusion of angiographically mild lesions, so-called vulnerable plaque. And I won't go into the background on all this, but I think you know most of all this. And no one's ever been able to prospectively identify which lesions were prone to suddenly progress and suddenly rupture. In addition, the event rate attributable to the progression of vulnerable plaques has never been prospectively assessed. So sometimes plaques will rupture and they're asymptomatic, or they'll cause heartburn, and then they'll heal over and just lead to atherosclerosis progression. And I was really impacted by this study, the Prove It TIMI 22 study about 6 or 7 years ago when it was first presented by Chris Cannon. And this was on its face a randomized trial of patients with acute coronary syndromes. They're randomized to either a standard dose statin or a high dose statin, and it showed the high dose statin led to better overall outcomes. But when you look at it, their primary endpoint here was MACE, death, MI, unstable angiogram requiring hospitalization, revascularization greater than 30 days, or stroke. And this was patients who were mostly medically stabilized with acute coronary syndromes. Then 69% underwent a PCI on average of day 7. And then they were randomized and then they were treated. So none of these patients underwent surgery. And there were two striking things about this. Number one, they followed the patients up to 2.5 years. And still, even though the high-dose statin was better, 22% of patients were still having major adverse cardiovascular events at 2.5 years. So a pretty high event rate, even with this definition. And when I started to try to understand this, I was asking myself, well, this is a really mixed population. 69% had PCI, 31% were treated medically. Some were capped at the beginning, some weren't capped at the beginning. So how many of these events were attributable to a problem from the PCI? How many were attributable to either restenosis, stent thrombosis, or other problems from PCI, either acute or late? How many of these were due to significant disease left behind? Maybe a patient never got cath and there was a 90% stenosis. Or maybe the patient did get cath and there was a diffuse 80% stenosis that they elected not to treat because it was too complicated. Versus how many of those were actually due to what we classically think about vulnerable plaque with progression. Maybe a 20% angiographic stenosis, which then ruptures 2 years later and causes a myocardial infarction. And there's no way to tell this from this data, and no study has actually prospectively looked at that. And yeah. Here, can we give Mike the microphone for Mike? Because we have other people.
Benefit was only in those 69% of patients who had a PCI. There was
the benefit of the statin.
The statin.
Yes.
And there was no benefit in the and then when you looked at restenosis, target lesion revascularization, it was reduced, but not related to LDL lowering. When you looked at new plaque rupture, new lesions and new vessels, that was lowered, but it was related to LDL lowering. So plaque rupture was in part mediated by LDL lowering, but restenosis was benefited, but not LDL lowering.
Did you get angiographic follow-up?
This is by clinical events.
This is by clinical events. So I'd love to see that paper.
Yeah, I'll send it over to you.
We were actually interested less in the statin effect, regardless of statin, but just what was causing all of these events. But I'd love to see that paper. So anyway, with that background, now about 6 years ago, we planned and performed a prospective multicenter natural history study using 3-vessel multimodality intracoronary imaging to try to quantify the event rate due to atherosclerotic progression and to identify those lesions which place patients at risk for unexpected adverse cardiovascular events. And so here's what we did in Prospect. This was a 40-center international study. We took 700 patients with acute coronary syndromes, and they either had to have unstable angina with EKG changes or non-STEMI or a recent STEMI at least 24 hours or so beyond. They had to undergo PCI of 1 or 2 coronary vessels. So they had to have real atherosclerosis, and we wanted them all to be treated. So they all had to be treated, and they had to have every single lesion in the native coronary tree treated that either caused the acute coronary syndrome or the doctors thought might cause them a future event. So in other words, if they wanted to stage them, they could stage them, but they basically had to, quote, stabilize the coronary tree with angioplasty. And once they had a successful and uncomplicated procedure, then they were formally enrolled into this observational study. So at baseline, we had a lot of measures for metabolic syndrome, including fasting insulin, creatinine, waist circumference, et cetera. We had a biomarker sub-study, which was a core lab sub-study for 7 different biomarkers that you see here. And then the unique part of the study was that we did 3-vessel imaging of the entire coronary tree. So we did the standard angiography, but instead of just kind of looking at one lesion and doing QCA of one lesion, working with Alexander Lansky, we developed proprietary software that would let us do QCA of every single millimeter of the coronary tree in every vessel, main coronary or branch, greater than or equal to 1.5 millimeters in diameter. So on a millimeter by millimeter basis, we could tell you the reference vessel diameter, the stenosis, the diameter stenosis, whether there was calcification, thrombus, eccentricity, everything. So I tell people that a standard, and Mike knows this, but a standard QCA takes a technician, one technician, about an hour and a half, maybe 2 hours to do a standard single lesion QCA. Prospect would take 2 to 3 technicians 2 days to analyze the coronary tree. And so every single millimeter of data. Then, in addition to that, they also had intravascular ultrasound imaging of the proximal 6 to 8 centimeters, all 3 coronary arteries. So if a stent was placed, they went through the stent, of course, but basically the proximal to mid and sometimes distal portion of the entire coronary bed, including the left main coronary artery. And we did it with intravascular ultrasound, with radiofrequency IVUS, which I'll describe, which is virtual histology by the Volcano system. And then about half the patients also had palpography, which is another way to assess stress-strain relationships. I won't be talking about that today because we're just completing analyzing that data now. Now, all the patients were treated with, quote, a maximum medical regimen, which was aspirin and Plavix for at least a year, high-dose statins with strong recommendations for beta blockers and ACE inhibitors. Patients had repeat biomarkers at 30 days and 6 months. There was a multi-slice CT sub-study in about 55 patients. And patients then were just followed up clinically. 1 month, 6 months, 1 year, at least 2 years, and we were going to go up to 5 years. And it turns out, and I'll show you when we get to the MACE curves, we truncated the follow-up at about, with a median follow-up of 3.4 years. But again, just clinical follow-up. If people came back with events, then we wanted to complete and repeat 3-vessel intracoronary imaging again with radiofrequency IVUS. So we attributed MACE, and this will be the definition of MACE I'll describe in a minute, to either so-called culprit lesions or non-culprit lesions. And when a patient came back with an event, basically based on a follow-up angiogram, we would have the Independent Clinical Events Adjudication Committee look at the angiogram, look at all the source documents, and decide where the event came from, which lesion of the coronary tree. And if it came from basically a originally treated lesion or 5 millimeters of the margin of that treated lesion, that was called a culprit lesion event. If it came from a new untreated area of the coronary tree anywhere, it was called a non-culprit lesion event. And we were interested, frankly, not so much in what happened at the stented sites. That's kind of old news. We were interested in what happened at the untreated sites, the de novo atherosclerosis. So the primary endpoint, if you will, was MACE attributed to the so-called non-culprit lesions. And we define MACE as either cardiac death, cardiac arrest, myocardial infarction, or rehospitalization, either due to unstable angina or progressive angina requiring rehosp. So anytime anyone wants to stop, it'd be fun to make this even more interactive than yesterday. Mike?
And when you say it was a non-culprit, I mean, they could have treated the wrong culprit artery.
Oh, absolutely.
Right, okay.
Yeah, absolutely. So, as I mentioned, we did this angiographic core lab analysis on every 1.5, every 1 millimeter of the coronary tree, anything 1.5 millimeters in diameter or larger. We also measured, in addition to actually quantitating and qualifying each segment, we measured the distance from the ostia at major branch points. These were registered and corrected for foreshortening. And as I'll show you with IVUS, we actually lined up all the IVUS with all the QCA. So every single millimeter of IVUS data was lined up with every millimeter of QCA data in a totally relational database. So we could tell you basically what the coronary tree looked like by angio, IVUS, and virtual histology, either by in a cast segment, for example, the left main or the proximal AD, or if you wanted to know from 3 to 5 millimeters from the origin of the left main coronary artery, or the first diagonal branch, or however you wanted to break it up, we could give you this data. We also had the core laboratory identify, and this has been the most confusing for people to understand, but it's actually kind of important, lesions that the core laboratory said by visual assessment there's some atherosclerosis there. So the core lab would say that looks like a lesion that by my eyeball is at least a 30% lesion. Okay? And we wanted to see if seeing some atherosclerosis correlates to future events at that site. And again, this data could be output, cast segments, lesions, vessels, every millimeter, any other parameter you want. So we did IVUS, both volumetric and cross-sectional analysis on a millimeter by millimeter basis. But this is just, of course, of the IVUS pullback, which is about, again, 6 to 8 centimeters. Each IVUS VH frame was co-registered to the corresponding QCA location, and this takes a huge amount of time to do into QC. We define an IVUS lesion as 3 or more consecutive frames with a cross-sectional plaque burden of 40% or more on each of those frames. And that's a standard IVUS definition of what a lesion is. So when we talk about lesions, it's 3 frames or more. Each IVUS frame is about a half a millimeter, so it's at least 1.5 millimeters of disease with 40% or more plaque burden. Now remember, you can have expansive remodeling, so you may not see that plaque in the lumen, but it could be totally invisible by angiography, but it's there by intravascular ultrasound. And then we did IVUS VH analysis using the latest volcano classification tree. And as I'll show you, plaque was characterized as 4 different tissue types, either fibrotic, fibrofatty, necrotic core, or dense calcium, and reported as absolute and relative areas and as volumes. And again, all this on a millimeter by millimeter basis. Then the core lab would look at each lesion and would classify it into the major types of virtual histology lesions, which I'll show you on an upcoming slide. Here's the upcoming slide. So here are the 4 different colors. If you look at these, you can see white is dense calcium, dark green is fibrotic tissue, light green is fibrofatty tissue, and red is necrotic core. So that's the combination of cholesterol, cholesterol esters, and necrotic cells that we think place patients at high risk. And as I'll show you, when you look at pathologically patients who have died of sudden death and myocardial infarction, most of them, about 75 or 80%, have been at the site of a ruptured thin-capped fibroatheroma. So these are the 5 types. Fibrotic, and there's detailed definitions for each of these I won't bother going into, but fibrotic is mainly plaque, which is mainly dark green. Fibrocalcific is mainly dark green with at least 10% dense calcium. This is 80% dense calcium. Pathologic intimal thickening is garden variety atherosclerosis. Okay, and this is usually a mixture of fibrotic and fibrofatty plaque with at least 15% fibrofatty plaque. Then there's necrotic cores, and any lesion with a 10% or more necrotic core is called a fibroatheroma. That's the pathologic definition. And if that fibroatheroma has a green cap on top of it, then it's a thick cap fibroathyroma. If it doesn't have a green cap on it, so it's just a budding lumen, then it's a so-called thin cap fibroathyroma. Now, pathologically, it's these thin cap fibroathyromas that have been strongly associated with, again, sudden death and myocardial infarction. A thin cap fibroathyroma is defined pathologically as 65 microns or less in thickness. Now, a limitation of IVUS and therefore VH is it's got a resolution of about 200 microns. So if I don't see a cap, all I can say is that that's probably, it's got something on it or it would have ruptured. All I can say is that it's probably less than 200 microns. Okay, so I can't say for sure that it's a pathological thin cap fibroathyroma, so we call it a VH TICFA, which means it's got less than 200 micron fibrous cap. Now, all of these, of course, we don't know for sure that this actually represents histology. Okay, this is called virtual histology, and I thought I'd put in there, let's see one thing, I thought I'd put some examples in. Nope, I guess not. Okay, that's okay. So basically what we're doing with this technique or with OCT or with near-infrared spectroscopy or any of these intravascular imaging techniques is creating a series of pictures. And then the question really is, does the picture correlate with future events? And we wanted to know on a lesion-by-lesion basis, do these pictures correlate with events? So let me show you how Prospect ran. And I don't know if we could put the lights down at all. Is that possible? So this is kind of a typical patient. This was, it can go down a little. That's it. That's about it. Okay. Perfect. For this image, it'll be worth it. So this was a 52-year-old man who came in February of 2006 with a non-STEMI due to a subtotally occluded LAD. Okay? So the LAD gets treated. Don't pay attention to the LAD. And then the patient came in, did fine for 51 weeks, and came in with a non-STEMI attributed to the circumflex. Now, this is what it looked like at the time of the LAD subtotal occlusion, before it was treated. Okay? And I show you this one frame because this shows you the arteriocaudal, shows you the nice circumflex artery. Okay? So I'm going to tell you that sometime 51 weeks later, this artery is going to cause a non-STEMI. So the first question is okay, you guys predict, where's the non-STEMI going to come from? Is it going to come from somewhere here in the proximal tree? Is it going to come from this stenosis here? This is what we would have had the core lab call one of those 30% or more stenoses. Okay? Is it going to come from this lumpy, bumpy area here? Is it going to come from one of these side branches and these obtuse marginals here? So what do you think? Who wants to hazard a bet? How many people think it'll come from a non-STEMI a year later come from here? Subtotal occlusion or occlusion up here. Okay? How many people think it's going to be at that, 30%, 40% stenosis? Okay? How many people think it'll be from somewhere down here? Okay? And how many people think it'll be from either of the marginal branches? Okay, so it's pretty equal, about a third, and a third. So here's what it looked like 51 weeks later. Okay, so 51 weeks later, you can see there's a ruptured plaque with thrombus at this site, right here, at this area that angiographically was 10, 15% stenotic. So by QCA, this area of the circumflex went from 28.6% stenotic to 71.3% stenotic, and it's got clear evidence of thrombus. So now let's look at what this looked like back then by intravascular ultrasound and virtual histology. So here is now at baseline. That's when we did the IVUS and VH of this. And here you can see this is the pullback, and this is the way virtual histology creates an initial map. It's got the 4 different colors that are stacked. And again, we look for red mostly more than anything. Those are the fibroathyromas. And here you can see there's actually 3 separate fibroathyromas. And if you want to look at just this area here, which is about 4 to 5 millimeters long, here is just that area. So there's the obtuse marginal branch, and that's how we line these things up, right? There is there. And then you're pulling back from distal to proximal. So this is the first fibroathyroma. There's the second. There's actually 3 fibroathyromas in the circumflex. This is the one that caused the problem. So here we can now look at it frame by frame. And here is each grayscale intravascular ultrasound frame. And here is each radiofrequency IVUS intravascular ultrasound frame. So for every frame, I could tell you the external elastic membrane measurement, the amount of plaque burden, eccentric, concentric, what the lumen area was, whether there's expansive remodeling, if it's eccentric or not. And as you can see, this here had a minimal luminal area of 5.3 millimeters squared. There's a lot of plaque here. You might not have thought there was this much plaque by just looking at the angiogram, which only shows you the lumen. It's a luminogram. But you can see there's a lot of plaque. It doesn't get down to 4 millimeters squared, which is our usual correlation with an ischemia-producing lesion by either FFR or by SPECT. And that's because this is the Glagoff phenomenon. It's mostly outward positive remodeling. When you look at this, there's a fair amount of necrotic core, but when you look at where the necrotic core is, it's mostly deep. Okay, and there's a specific definition. It's got to be at least 30% of contiguous necrotic core abutting the lumen for it to be called a thin-capped fibroatheroma. So the core lab reads this as a thick-capped fibroatheroma. The length was 6.8 millimeters. Here's the reference vessel diameter stenosis. I mean, we've got about 100 baseline variables that we measure on this lesion. Now, this is one lesion at baseline. The core, I could tell you what that lesion looked like at baseline. I could tell you what this looked like at baseline, what the left main looked like at baseline, and the area in the LAD or the right coronary artery. So the unique thing here was that we prospectively created all these lesions at baseline, so we now have the denominator. So I now have the denominator of all thick-capped fibroatheromas. This happens to be one that ruptured. There'll be lots of other thick-capped fibroatheromas that didn't rupture and didn't cause clinical events. This happens to be one with an MLA between 4 and 6. Okay, I've got lots of other lesions with MLAs less than 4 or greater than 7. And so we've got we've got thousands of these. So we've got the denominator. So on a lesion-by-lesion basis, we can tell you which areas of the coronary tree caused future events.
Gregg, how real-time is the virtual histology? Is this all recreated afterwards by computer?
Yes.
So you don't see this?
No, this was blinded. The operators were blinded to all this.
But can it be real-time, or what's the state of the technology?
Yeah, it can be, and now it does come out real-time. But one of the limitations of virtual histology, though, is it is difficult for operators to assess this much information. And unless it's just really crystal clear, obvious, you know, if, for example, near spectroscopy, it's pretty easy to assess. It gives you this big yellow color or it's just dark red color. But there's a lot of subtleties about whether it's thin-capped, thick-capped, whether it's contiguous lesions or not.
So it's still a research tool right now.
Yeah, and I mean, that's one of our challenges. If you think there's something here, how to translate that into the clinic to actually be able to use it. Yes?
It's a great case, and just one limitation I think that Mike Gibson brought up already was that in this case you don't really know where the infarct is. We have a lot of information about the artery. An LAD non-STEMI might be unusual. So we don't have a muscle picture to say, was the original non-STEMI actually in the circumflex distribution, and is this patient recanalizing, infarcting in the same territory?
Well, no, we do have all the baseline.
But so they came in with it.
Show it to you. But we have all the baseline films that were treated. Okay, so we've got the core lab that's also adjudicated where all the original events were as well.
Yeah. So the investigator decided that the first non-STEMI was the culprit was the LAD. Right. But not the circ. And I'm just bringing up the point that maybe the culprit all along was in the circ for the non-STEMI and not in the LAD, even though it's more tight.
In this with hyperenhancement might have been a useful addition.
Yeah, but I think when you've got a subtotally occluded LAD with anterior ST
Slightly.
elevation, it's pretty easy that it's
yeah, if it's ST elevation, I agree with you.
Yeah. And I'll show you when I get to the demographics. Almost all the patients had ST segment elevation or depression with positive troponins. So there were very few cases at baseline that were.
I got you.
Yes.
Yeah, I just had a question. If you recall how the proximal segment and the juncture between the proximal and MIG segment were characterized by the IVUS. Do you recall in terms of atheroma and so forth?
So which area exactly?
Well, the proximal segment of the circ, as well as that juncture right there, the intersection between the proximal and mid.
Right. So I can't tell you here exactly. This I've lined up for you, but as you can see here, presumably this is where the LAD starts. So here, very proximal, you've got a lot of what is mostly fibrotic or fibrofatty plaque. Okay, this would not make 10% necrotic core. Okay, then somewhere shortly thereafter, you do have a significant necrotic core. Actually, whether this is contiguous or not, it looks like it's separate here because it probably falls below 10% for 3 or more frames. And then here we are here, which is from there to there.
Greg, do you have
So, but this is
inter-observer
all
variability data on the necrotic core? There was an article a couple weeks ago that said this necrotic core measurement is not that reproducible across observers.
Well, that's why we do core lab. It depends. I mean,
But within
in
the
our
core lab,
it's very reproducible. It's extremely reproducible in a core lab setting. Yeah, and we've actually published that. Okay, so the clinical events committee was critically important here, and they spent a long time on each of these cases, and they adjudicated without knowing what the baseline angiography or ultrasound was. They looked at follow-up MACE, and they adjudicated the MACE during follow-up to either whether it was culprit lesion stent related, and I won't talk about too much of that today, although it's pretty interesting. There was either stent thrombosis episodes, restenosis, or new side branch lesions, which haven't been described all that often, but as a cause of future MACE. Or they're non-culprit lesion related, and we broke these down to either those with rapid lesion progression by QCA. The case that I just showed you went from 28.6 to 71%, which is what a lot of people call a classic vulnerable plaque without rapid lesion progression. And we arbitrarily predefined rapid lesion progression as the QCA diameter stenosis increasing by 20% or more from the baseline to the follow-up angiogram. And then there were a few cases that we knew were going to be indeterminate. And that's an important group because these are the patients who died of sudden death or patients who we couldn't get back for an angiogram. And unless you had an angiogram or an autopsy, you couldn't say for sure exactly where the event was coming from on a millimeter by millimeter basis. So this was a real serious attempt to do a very careful prospective registry. Patrick Sorois was the co-PI of this. Bernard DeBruyne was involved. This was actually led by Abbott and funded by Abbott, and it was pretty interesting that we were trying to get diagnostic companies for a long time to do this study, but they never could afford it. And so finally Abbott stepped up, hoping that it would basically create a field of vulnerable plaque. You know, if we could identify those lesions that were going to cause death or MI, then potentially, there could be a local or regional interdiction strategy. So they funded this study. So again, here's all the details of people that were involved. Yeah.
You had a DSMB chair for registry, which is a very
Yeah.
novel and I think a good thing to do. What was the charge of the DSMB for a registry?
It was mainly we were doing 3-vessel IVUS, okay, which is not routine. So the DSMB wanted to make sure that it was safe and there weren't an excessive amount of complications associated with the 3-vessel IVUS. And there were some complications associated with it. I don't think I have those slides in there, but I think the major complication rate associated to 3-vessel that was attributed to the IVUS procedure itself and nothing else was, as I recall, 1.1%. So about 6 or 7 patients had, and nobody died from IVUS, but there were like 3 or 4 MIs, and there were some target vessel revascularizations from dissections that were caused. There was even one wire perforation that was caused by trying to get the IVUS down. So it's not risk-free. And so that has to be, again, when you're considering if you want to do this, prospecting, if you will, to look for vulnerable plaque, you've got to take into account a 1% MACE rate. And that was Steve Steinhobel before he went to the medicine company. So altogether, between October 2004 and June 2006, we enrolled 700 patients, 400 from Europe and 300 from the United States. Here's the high enrolling sites. And there were 697 patients that we actually have data on. 3 patients got enrolled, and the Europeans never had a consent form signed, so we had to exclude those patients, unfortunately. But you could see here, 30% of the patients had a STEMI, and then they were studied a day or more after the STEMI. 65.6% of the patients had non-STEMIs with troponin elevations, and only 4% of patients had unstable angina with EKG changes. This is some of the demographics of the patients. They're fairly typical. 17% diabetics and only 3% insulin-dependent diabetics or insulin-requiring diabetics, and that'll turn out to be important. I wish there were more, but that's important. You can see a lot of patients, remember, patients had to have successful and uncomplicated angioplasty of 1 or 2 vessels, although there were patients that have triple vessel disease. This is by QCA. And some of those are significant and some of those are not significant. What else is important here is probably, most importantly, that the median follow-up was 3.4 years. So this is the medications that these patients were on, and this is a little different than your typical ACS population, and this is important when you try to interpret the results, because number one, they had a successful uncomplicated angioplasty. Number two, it was 1 or 2 vessels. Number three, they weren't in the trial until at least the operator felt visually they had treated everything that needed to be treated. Okay, so this is a successful, even though it was a high-risk group at baseline with almost everybody troponin positive or recent STEMI, they all were successfully treated. Then they were carefully followed in a clinical registry with frequent office visits. And you can see here the aspirin use was high through the 3 years of follow-up. Thienopyridine use was not as high as I think it would be today, but it was high initially through the first 6 to 12 months. Statins were in about 85% of patients, beta blockers about 85% of patients, and ACE and ARB in about 70% of patients. So this gives you a sense, this is the imaging summary, and gives you a sense of how much data that we've got on the baseline films. You can see on angiography, we've got angiographic data on all 697 patients. The average left main measures 9.3 millimeters, and again, we've got millimeter by millimeter data. Here's the distances for the LAD circumflex. The bottom line is we have 305,000 millimeters of data of coronary artery. By IVUS and virtual histology, we have somewhat less data because, number one, we only do the first 6 to 8 centimeters. Number two, VH data only registers if there's significant plaque there. And three, there's always some dropout of the signal. It's not perfect. But you can see that we did measure 6 to 8 centimeters of the LAD, circumflex, and right coronary artery, which is exactly what we intended. Altogether, 130,000 millimeters of IVUS and almost 30,000 millimeters of virtual histology data. So just to give you, I could spend the next hour and a half just showing you the baseline findings, but I'm only going to show you 2 slides, and that's to kind of show you the virtual histology data. First of all, let me tell you, by QCA, there's almost no lesions left behind that are more than 50% stenotic by QCA. There were a few of the lesions that were left behind. There might have been about, I think the number was something like 60 in the 600 patients that were more than 50%, but they were mostly in small little branches. So there is some diffuse disease left behind, but not, quote, by your eyeball test severe. By virtual histology, at baseline, we characterized 2,811 lesions and 611 patients that had lesions. This just gives you the mean plaque composition. But more importantly, this is the overall plaque, the way plaques were characterized. So very few fibrotic or fibrocalcific plaques. Pathologic thickening, 36% of the plaques. And the rest are fibroatheromas, 57%. When you break them down into thick-capped or thin-capped, about 19% of all the plaques were thin-capped fibroatheromas. 36% were thick-capped fibroatheromas. And then we have multiple subclassifications that I'm not going to spend a lot of time on. So how many of these are there? And, this has been a constant battle, frankly, that's been going on by the group of Peter Libby, who says that atherosclerosis is a diffuse inflammatory disease and acute coronary syndromes are caused by these types of lesions all over the coronary tree. And then there's another school of thought that says, no, this is a focal manifestation of a systemic disease, and there's actually a lot of pathologic data to show that, at least at any one point in time, and that's actually what we found here. So if you looked here, we found that 51% of patients had one or more of these VH TICFAs. So it was a mean of about 1 per patient, ranging from 0 to 7 per patient. So 49% of patients had none, 27% had 1, 12% had 2, 6% had 3, and about 6% had 4 or more. So for the most part, this was pretty focal, and there's just a few of these per patient, when you even find them at all. So the most, I think, interesting finding, one of the interesting findings was the MACE rate, and then what caused the MACE rate. So this was the overall MACE rate over 3 years. And you can see it's about 20.4%, which, given that we've got a slightly different patient population than the PROVE-IT trial, it's a slightly different MACE definition, it's not all that different than PROVE-IT. So a fair number of events over 3 years. And a lot of these patients, 60% got treated with drug-eluting stents, which you would expect would decrease the MACE rate, et cetera. So this is the MACE rate that was attributable to culprit lesion-related events, about 13%. So this is, again, stent thrombosis, restenosis, side branch lesions. And this is the rate that these were the events that were attributed to non-culprit lesion-related events. And then there were a few events that were indeterminate because we didn't have angiographic follow-up on those patients. So this was kind of the 50-50 rule. About half the events were due to problems at the original treatment site, meaning that we could still, if we want to reduce this MACE rate, we still have to do better at the lesions we're initially treating, and half were due to untreated lesions. This was also a little bit lower than we had expected, though, especially at the untreated lesion site, 11.6% over 3 years. So that's about 4% a year. So it's actually relatively low, and I'll show you the breakdown of those events in a minute. This also shows you just the 1 year, 2 year, and 3 year rates, and you can see here that about 2/3 of the events occurred in 1 year, and then the curves were actually somewhat plateauing after that. If you look at the culprit lesion-related events, as you'd imagine, a slightly higher percentage occurred within the first year than the non-culprit lesion-related events. And basically, because this was plateauing, it was especially the non-culprit curve, it was pretty much decided to stop the follow-up at 3.4 years.
Are you going to show us the data, Gregg, by ST elevation patients and non-ST elevation?
I don't think I have that in here. It's actually not. This is the type of events. It actually wasn't predictive one way or the other.
So the distribution of disease is not different by non-ST and ST patients?
Well, the distribution of disease was slightly different, but the correlation with events and the number of events was not different. Not different. So this is
Gregg, to build on that, are you going to show how far down the tree the lesion occurred? I mean, we co-authored a paper where we showed that in all the angiographic data we'd collected that the vast majority of the lesions occur in the first 25%. Yeah. The new lesions occur in the first 25% of the tree.
So there's a lot of data about that, and it looks like it's really the first 4 to 6 centimeters of the LAD in the circumflex. Then it usually skips the first centimeter of the right coronary, and then it's the proximal mid and distal right. It goes a little farther in the distal right. And we basically replicated that, except we also, in this prospective study, have more lesions distally, than you would have expected. And I think that's one of the problems with the retrospective studies. People aren't going to angiograms for a lot of the minor events, or they're not caught for whatever reason. So we did see somewhat more distally here, but it pretty much recreated what you would have expected. So this is the types of MACE, and this was kind of a revelation. This is all patients, and if you look here, now this is 3 years of follow-up. It's 1.9% cardiac death, so about 0.6% a year, which again is pretty good. Very few cardiac arrests. This is all non-hierarchical. Very low rate of myocardial infarctions, so about 1.1% a year. Yesterday I was talking to a few people about how hard it is to get event rates in these clinical trials now. And most of the events were angina. And in fact, most of it was increasing angina requiring hospitalization, with about 8% adjudicated as one Braunwald type of unstable angina. So composite rate of 20.4%, but if you look at the hard events, the kind that we really wanted to prevent by identifying lesions that were, quote, vulnerable, or at least would place patients at risk for future events, only about 4.9% over 3 years, so about 1.6% a year. Now, if you look at culprit-related and non-culprit-related events, let's just focus here on the non-culprit-related events. There were no deaths, no cardiac arrests, few myocardial infarctions, and again, mostly angina. But we've got this group of indeterminates, and the group of indeterminates are where most of the deaths lie, because these were sudden deaths that patients didn't have a follow-up angiogram. So if we did a sensitivity analysis, and if we assumed that all of those indeterminate events were non-culprit lesion-related, which we know is not true. We know that a few of those were stent thromboses, or would be if we had pathology. But let's say they were all non-culprit lesion-related. This would be the absolute worst that you could see for non-culprit lesion-related events, and that would be an overall hard rate of 3 years of 2.9%. So overall, this was good for the ACS field, a good conclusion for the ACS field and the PCI field, and I think it says that if you have an acute coronary syndrome, even troponin-positive recent STEMI, you successfully treat that patient, you put them on good medical therapy, and you follow them up, they are going to have a very low rate of hard events over 3 years. Bad for the vulnerable plaque field, potentially, because, I mean, if this is what you were trying to prevent, 3% rate at 3 years, that's, not going to get you very far. But there's a lot more we can learn from this scientifically. So the next thing we did was we looked at whether or not these lesions rapidly progressed or not. So basically when the patients came back, did they look similar to what they looked like, or did they actually have big changes, the way I showed you on that other angiogram? And now this is just the non-culprit events. 11.6% non-culprit, and about half of these, a little more than half, had rapid lesion progression, and about half of them didn't. Okay, so now non-rapid lesion progression is less than 20% diameter stenosis. Sometimes it can, change with a new thrombus, and you don't get a diameter stenosis change. But again, half of them angiographically did not get that much more severe. The median time to the event was different, as you might expect. If you had no rapid lesion progression, those patients, more likely had severe disease at baseline. These might have been patients with a 30% stenosis where the IVUS showed a 3 millimeter squared cross-sectional area, an ischemia-producing lesion at baseline. They came in with progressive angina. And they came in, on average, within 9 months. Within less than 6 months. If you had rapid lesion progression, these were slightly later events, and they came in a little bit over a year. We tried to look at the differences between those non-culprit lesions with versus without rapid lesion progression, and as you can see here, the biggest difference was, you can see the ones with rapid lesion progression went from 27% at baseline by QCA to 72% at follow-up. This is QCA. The ones without rapid lesion progression did progress a little. Went from 49% to 59%, which was highly statistically significant, but obviously less. Okay, so here's where it gets the most interesting, and that is to try to see if on a lesion-by-lesion basis we could predict, even though the rates are relatively low, which lesions were going to go on and cause a problem. So we had a huge database here, and we looked at 152 different baseline variables. We had 19 demographic, history, and physical examination variables. We had multiple different labs. It's a long story. The only biomarker that we looked at was CRP. I'll save that one for another day. There was this angiographic non-core lab issue about whether there was a visible, visually assessed diameter stenosis lesion. There were 12 different QCA measures, 20 IVUS volumetric measures, 74 virtual histology measures, and a few others, including medications. So the first question was, on a patient level, could we predict which patients were going to have a future event? And the answer was, it was very hard to predict which patients were going to have an adverse event. This is a univariate analysis, and I'll show you a multivariable analysis. But the only ones that really stood out were insulin-dependent diabetics. Okay, they had a hazard ratio of 4.1, and again, this is univariate. 41% of patients had an event at 3 years. But this was a small number of patients. There were only 21. So that's a real limitation of this study. Non-insulin-dependent diabetics looked like there was a trend towards an increased rate, but it didn't reach statistical significance. Hypertension had somewhat of an increase. Prior PCI had somewhat of an increase. If there was a visible lesion, okay, by angio, that means that patient was at somewhat risk. Now, it doesn't mean that the patient was at risk for a recurrence at that lesion. It just means that the patient was at an increased risk. Conversely, if there was no visible lesion, and this is one of the few negative predictive variables that I think were very helpful, if you looked with your eyeball at the coronary tree by angiography and you said there's nothing there that's even 30% or more, those patients had an extraordinarily low rate of, and this is actually 3.4-year data now. It's only 3.2% events, almost zero, 1% a year, if you don't see something by angiography. And the number of diseased vessels is also correlative. Where it gets more interesting is when we now look and ask, well, on a lesion basis, can you actually predict which lesion is going to have an event? And QCA was useless. Okay, whether it was 10% by QCA or 40% by QCA, that was totally uncorrelated. Whether the area was calcified, non-calcified, longer, shorter, didn't help at all. But the IVUS data did. And again, now this is on a per lesion basis. Lesions with an MLA less than the median, this is minimal luminal area, less than the median versus greater than the median, that is more severe stenoses, had a 7-fold higher likelihood of that lesion having a future event. Lesions with high plaque burden, okay, so the amount of plaque at that lesion site, had a 7-fold increase of that lesion having an event. Longer lesions, distance was important. External elastic membrane was important. Remodeling index was not. So,
Greg, can I ask a question? When you have this many lesions per patient, and it's almost like you're taking the blood pressure in two different arms and saying you have multiple measures per patient, so you have to adjust for the correlation in behavior within the patient.
And we did that in the multivariable analysis. Yeah. We did extensive modeling to look for linear correlations between different variables, and I can go into that. But
this is the hazard ratio. What about the area under the, like you showed yesterday for platelet inhibition on a per patient basis?
Right.
Isn't that?
I'm not going to show you AUC data. We didn't have enough data to, I think, create reliable curves, ROC curves and AUC data, but I will show you some positive and negative predictive value data. But this is all univariate. Now, this is what got really interesting, and that is, I must say, I was a little skeptical about virtual histology going into this. Very skeptical, as a matter of fact. I was absolutely prepared for this to have no correlative value whatsoever. And we were pretty surprised at what we saw. I've got this similar graph with all 5 different lesion types, but because there were so few fibrotic and fibrocalcific, I lumped them all here. But basically, VH-TICFAs had a strong correlation, univariate correlation between future events with a hazard ratio of 3.9-fold. Thick cap fibroatheromas were intermediate, weren't correlative, weren't protective, and these types of lesions, most of which were fibrofatty, had a 5-fold less likelihood of having an event. Now, we've got to put all this into a multivariable analysis. And again, you've got to do this and maintain parsimony and look for linear correlations because you've got a limited number of events. But that was all done. And could we predict patient-level events? Well, there were only 2 predictors of patient-level events, and one was insulin-dependent diabetes, and the other was prior PCI. But that doesn't help too much. Could we predict which lesions were likely to have an event? And there were 3 variables that came out in multivariable analysis as being predictive. The first is one you might have thought, and that is a small minimal luminal area. Okay, so again, we know that small minimal luminal area correlates with a positive FFR or spec thallium. So in other words, an ischemia-producing lesion. And it makes sense that some of those patients are going to be at risk, certainly, for future angina. And that fell out as significant. But these other 2 have not been shown before. And the first was the amount of plaque. And the strongest predictor of future events was the amount of plaque at the cross-section of the lesion by intravascular ultrasound with a hazard of 5-fold. And then the other one that came out independent was the presence of a VH-TICFA. So the presence of plaque composition, okay, more than just plaque severity, was a significant multivariable correlative events. So now let me kind of help put all this together. So let's say that those are the 3 important variables to say whether one individual lesion has an event at that lesion in the future. If you had none of those lesions, okay, and you can see there's 1,650 lesions that we characterized at baseline that had none of those 3 characteristics. Your likelihood in 3.4 years of having an adverse event was 0.3% at that lesion. So that's better than FFR. That's better than anything, okay, 0.3%. If you had one of those, whichever one, but only one, then that lesion has a 4.8% likelihood of having an event. If you have 2 of those lesions, it's 10.5% likelihood of having an event. If you have all 3, there's only 29 lesions that had all 3, but 5 of them had an event, 18.2% likelihood of having an event. Let me show you a few more correlations. It's not just about how severe the lesion is. So, for example, this is the likelihood of having an event with the characteristic in red versus without the characteristic in blue. If you have a small minimal luminal area, and again, angiographically, these all look mild, okay, especially all the IVUS ones. If you have a small minimal luminal area, yes, you can see a 5-fold higher hazard rate by this univariate analysis. If you have a small luminal area and a lot of plaque burden greater than 70%, now the event rate doubles for any given amount of small luminal area. And then, of course, if you have small luminal area and a lot of plaque, and that plaque happens to be a thin cap fibroatheroma, now it almost doubles again. I'll show you a few more correlations. This is really interesting. So this is now, these are lesions that are all so-called VH tikphas. So this is the VH tikpha in itself. You can see increased the hazard of having an event about fourfold. A VH tikpha with a small lumen doubles that. VH tikpha with just a lot of plaque, but not necessarily with a small lumen, further increases it. And then if you have a higher event rate with all three different lesion types. So remember this progression. Tikpha with a small luminal area, with a large plaque burden, and with both a small lumen area and a large plaque burden. Now let's look at all the thick cap fibroatheromas. And here you can see there's still somewhat of a relationship. The thick cap fibroatheromas really don't predict or don't protect. And if you go get more severe with those, smaller luminal area, larger plaque burden, yeah, the event rates go up, but not all that high. And now where it gets most interesting is look at all these other three lesion types. Here, you don't have events with these lesions, regardless of how severe the lesion is. So, any questions on this before I get to what we think the conclusions are? Okay, so first I'll give you some data conclusions to try to pull this together, and then I'll give you what I think the clinical implications are, and then I'd love to hear what your implications are. So from this trial, the first real prospective natural history study of atherosclerosis using multimodality imaging to characterize the coronary tree, we conclude that about 20% of patients with ACS successfully treated with stents and contemporary medical therapy developed MACE within 3 years, with adverse events equally attributable to recurrence of originally treated culprit lesions, representing treatment failure, and to previously untreated non-culprit coronary segments. About 12% of patients developed MACE from these non-culprit lesions during 3 years of follow-up. Patients treated with contemporary medical therapy who develop non-culprit lesion events present most commonly with progressive or unstable angina, and rarely with cardiac death, cardiac arrest, or myocardial infarction. While the plaques which are responsible for unanticipated future MACE, we're not calling these vulnerable plaques, but these are the kinds of plaques that put patients at risk after you've angiographically, quote, treated the coronary tree. They're frequently, almost always, angiographically mild. Most untreated plaques which become symptomatic have a large plaque burden and a small luminal area, which is detectable by IVUS but not by angiography. Only about half of new events due to non-culprit lesions exemplify the classic notion of vulnerable plaque. That's rapid lesion progression of a mild angiographic lesion, while half are attributable, for the most part, to unrecognized and untreated severe disease with minimal change over time, although there is some progression in those lesions. The prospective identification of non-culprit lesions prone to develop MACE within 3 years can be enhanced by characterization of underlying plaque morphology with virtual histology, with VH tikphas representing the highest risk lesion type. And Renu Vermani has had this construct that she's published multiple articles in the New England Journal and ATVB, that you go from a stable phenotype, which is mostly exactly what we found, pathologic intimal thickening, fibrotic fibrocalcific plaque, to then you get a necrotic core, which develops under the surface, which then gets more metabolically active, macrophages infiltrate, et cetera, and then you get a thin cap fibroatheroma, which then ruptures. And that's actually what we saw here. The pathologic intimal thickening was protective. It was not an advanced lesion. Fibroatheromas with a thick cap were in between, and thin cap fibroatheromas, even by IVUS, which again is 200 microns or less, were the highest risk. And the combination of a large plaque burden, as measured by IVUS, and a large necrotic core without a visible cap, that is VH tikpha, identifies lesions which are at especially high risk for future adverse cardiovascular events. So this is where, people start, nodding off and saying, well, what do I do with all this? What are you recommending? I mean, should we be looking for these lesions, and should we be treating these lesions? So this is what our implications are, and this is what we've got in the manuscript, which is almost in press, I can say, in a prestigious medical journal. The relatively low prevalence of high-risk lesions, only about 1 in 5 patients had one of those really high-risk lesions with either VH tikpha, plaque burden, or 2 out of 3. Coupled with the fact that when they become symptomatic, they usually present with angina and not death or MI, suggests that 3-vessel imaging to identify and prophylactically stent these lesions, which is what we were hoping Prospect 2 was going to be, is in ACS patients who are revascularized and treated with optimal medical therapy is not warranted. Okay, so you got a 1% MACE rate just to find these lesions, and they rarely, serious MACE rate, and they rarely present with death and myocardial arrest. For the most part, they're not that common, and when it occurs, you can treat them, effectively by getting them in the hospital because they're not infarcting. Similarly, what do you do if you find one of these high-risk, non-ischemia-related lesions? What if you happen to be doing VH-IVUS because you're guiding, using a stent? You're using IVUS to guide your procedure, and you happen to find another one of these lesions. Or if it happens to be at the edge of the stent. This comes up all the time, okay? And if you find one, let's say he's got a 3-year event rate less than 10%, greater than 10%, you might think that, with good stenting, especially with drug-eluting stents, we can reduce that to less than 10%. That would be a hypothesis, okay? But again, short of having a randomized trial, okay, since most of these patients present with angina, prophylactic DES, in my view, can't be recommended absent a large randomized trial. So if you happen to see one of these things in an angiographic 10% stenosis, but you see a big bulky plaque, today I can't recommend that you put a stent in there. However, this is what I think is most important, and I mentioned this a little bit yesterday, millions of patients a year who are not being diagnosed with coronary disease, who are not on optimal medical therapy, who are not being closely followed in a physician's office, are dying, arresting, or developing a myocardial infarction every year around the world. Probably about 750,000 to 1 million in the United States alone. And to me, this suggests that future investigation should focus on those types of patients, because I think that the findings from Prospect are going to apply to those types of patients. We would need a study to actually prove that, but I do believe that that would be the case. These are the high-risk patients that need some sort of intervention, whether it's intensification of medical therapy or even more. So I believe we ought to be looking at identifying either asymptomatic or minimally symptomatic patients with large plaque burden, small MLA and TICFAs through non-invasive screening, for example, MSCT, for consideration of enhanced medical therapy and maybe even possible angiography in the most severe cases. So if we can convert those patients into Prospect-type patients, at least in the kind of, some of those patients are going to have 80-90% stenoses, unsuspected. They probably, if they're ischemia-producing, should probably prophylactically treated. Others are going to have some of these vulnerable plaques left behind. Those should get intense medical therapy, close follow-up, and maximal medical intensification. So that's kind of it. So this has been kind of a fun 6-year journey. It's really, I've tried to, distill down what was an incredibly complex amount of data. And there's a lot of people, that were tremendously, did a huge amount of work on this, especially Akiko Mihara in the IVUS and VH core lab, who just lived and breathed, this database for about 4 years, given the amount of work this was. I think the highest compliment that I received from this study was Patrick Siroy's, and they've got this unbelievable IVUS and VH core lab coming up, and he was the co-PI and basically congratulating us, saying we never could have done this. To have characterized all these lesions prospectively and linked up everything in the coronary tree and followed it, and I hope we never do it again, because it probably took 5 years off of my life. But anyway, hopefully it'll provide some insights into atherosclerosis. We're getting beyond just severity of atherosclerosis. I think plaque composition is important. Plaque activity, which we didn't directly look at in this trial, is important. We got to get to endothelial dysfunction, et cetera, if we're going to get smart. So thanks very much.
Absolutely fascinating questions.
So you have serial medical therapy in these patients?
What do you mean serial medical?
In other words, when they had their visit at 6 months, a year, et cetera, did you recollect medications? Do you know, for example,
I showed you that we had a slide on that.
And so, can you now define what optimal medical therapy is? In other words, using some sort of landmark technique, can you begin to tease out, is it antiplatelet therapy, is it lipid-lowering therapy, and do you have the response to therapy?
Yeah. We only looked at that from the time of discharge. At the time of discharge, everyone was on aspirin, everyone was on Plavix, and almost everyone was on a statin. So 85% were on a statin. So if you look at that, and then the 80 and 70% of patients that were on ACE inhibitors and beta blockers, it didn't seem to correlate. we have, again, the compliance rate was so high, it's going to be hard to tease out the ones that didn't do well.
Yeah, no, it was a remarkable study, and congratulations, making progress in coronary disease 1 millimeter at a time.
Yeah,
no, it is. It's a really amazing data set. The couple quick questions. Question one, I think you actually have the answer to the idea of should you intervene in that plaque with the high-risk features, 10% risk over 3 years. If you look at the vessels you intervened on, in the culprit vessels, right, you have a 13% event rate.
Right.
So if you extrapolate that out, which is not quite exactly fair, only way you could make that lesion worse is if you intervened, where you would actually increase event rates by putting metal into that vessel.
Well, it's actually probably not fair to extrapolate that. The reason...
Spoken like a true non-interventionalist.
Those initial lesions were, for the most part, presumably ruptured plaques, thin cap fibroatheromas, high stent thrombosis rate, high embolization rate, high event rates, et cetera, versus an angiographic 10% stenosis, even if there is plaque. So we actually published, Jeff Moses was the first author, an article from 4 different drug-eluting stent trials where we looked at patients who got in your routine BES versus BMS trials that had a QCA diameter stenosis less than 50%. They weren't supposed to get in, but they got into the trial, and there were about, as I recall, 240 or so such lesions out of a database of 2,000. And half are randomized to DES and half are randomized to BMS. And so these are kind of mild lesions, maybe a little bit similar to these. And those patients, when you follow them out to a year, they had an event rate of something like 14% with bare metal stents and like 3% with drug-eluting stents. So actually treating these relatively non-bulky, stable lesions with drug-eluting stents might have quite of a low event rate.
And this is another second question is a follow-up off of Mike's one, which is the idea that, at least in this analysis, and I can understand there's so much data here, you've looked to sort of lesion by lesion looks as opposed to the idea of is it sort of a cumulative amount of plaque that patients had or the degree, integrated in across patients? Could you gain value by looking across?
Yeah, we've actually got that data, and it's, as you say, it's just a huge amount of data. We're trying to figure out how best to analyze that and how best to describe it. I mean, we could look at total amount of atherosclerosis. We could look at worst cross-section anywhere. We could look, there's a lot of different ways to look at that. But I think we will have data on that, and I would bet my bottom dollar that it's going to show the greater burden of disease, the more necrotic core, et cetera, are also going to be correlated with events.
A great study. Do you have enough data to suggest that the TICFA lesions, some of them convert to FA, and is there any evidence that there's a dental sealant or a medical therapy that promotes that?
Yeah. So the answer is we got on the patients who came back, on about half of the patients, we had requested that everyone do repeat 3-vessel imaging, and about half of the sites did do that on about half of the lesions. So we do have a lot of that data. So we're going to be able to use we don't have routine systemic angiographic follow-up. We talked about that, but that would have changed the natural history of the study. So we haven't done that analysis yet. We're in the final throes of having all of that analyzed. However, we did publish with, I think Akiko Mahara was the first author, from a VH registry that we did, the temporal stability of different plaques. And TICFAs turn into thick cap fibroatheromas and vice versa, and less commonly, fibroatheromas turn into pathologic intimal thickening and vice versa with over a 6 to 12 month period. So that was published in JACC about a year ago, and it's the only data I've actually seen that actually addresses temporal stability. It was in kind of a hodgepodge of lesions from a variety of different sources, but it does show that certainly these plaque types can change. What, in your opinion, is the sealant? Diet Coke? Well, we don't have a sealant right now. I mean, I was hoping it was going to be I was thinking it might be a regional therapy, such as photodynamic therapy or something like that, but that really, there just hasn't been any funding to progress with that lately. I don't think there is a sealant. I think we need to get beyond statins because if you look at the rate, we're doing okay with statins, but I mean, I think we can do better, and whether that's HDL raising therapies or something else, we have to get there.
I know it's running late. Just were there any data to see how virtual histology might help you with the interventions we are doing? In our lab, when we use it, often at the edge of the stent, as you described, either in a STEMI or a non-STEMI, you see that the stent covers all of it, but not more of it. Did those patients, are they the ones that had events downstream that had ruptured plaque that wasn't fully covered with a stent?
So we've not yet completed the culprit lesion analysis, but we are doing that. So we've got all that data on culprit lesions, and that's a real question. I mean, what if you were going to put in an 18-millimeter stent, but you really see, while it's not a severe lesion, there's more necrotic core at the edge.
Should you use more?
Should you use long or not? Now, Renu Vermani says that when you stent a necrotic core with a DES, it doesn't heal. On the other hand, she says if you put a DES in the edge of a necrotic core, that's also a predictor of stent thrombosis. So what's the right thing to do? We don't know. So we'll get that data, and hopefully within a year, 6 months or so, that'll come out.
Yeah, this is very different than what we'd done in the late 80s and early 90s, which were atherosclerosis regression trials, where we would do an initial angiogram and look at a follow-up angiogram. And there you have complete ascertainment of what's happening anatomically. Here, it's the symptomatic patients who come back. So you might get some different answers. I mean, about 20, believe it or not, 20% of the MIs out there are asymptomatic. We know from some studies. So you may have missed some of those events. Sure. One of the things that fascinated me wasn't just that the lesion is a risk factor. This is about lesions. What about risk factors which are rheologic risk factors, the shape of the flow and the shear stress? And what I published in 1993 is that disease progression, at least diffusely, is related to low shear stress, but plaque rupture is more of a high shear phenomenon. So you have two different things. And then finally, did you look at things like the pulse pressure and heart rate to look at oscillatory shear as a risk factor for plaque thrombosis?
So we've looked at heart rate. We've looked at systolic blood pressure and diastolic blood pressure. We didn't look at pulse pressure yet, but those three didn't correlate. Bifurcation lesions didn't correlate with events.
But you can download the software, Greg, called Fluent, where you take the shape of the artery and download it, and you can model the shear stress. Yeah. And what we did is in that millimeter by millimeter basis, look at shear at every millimeter along the artery and look at disease progression and plaque rupture. So you could take your database and apply it a new way.
That's interesting. So that we haven't done. I'll talk to you more about that. We haven't done that.
Fluent is the name of the software.
You know, Peter Stone, of course, in Boston is doing a lot of endothelial shear stress modeling, which will be interesting. We do have this palpography data, which, while I don't think it's going to be a large enough database to be definitive, that also looks at stress-strain relationships on a given, plaque basis, wherever you are at that point in time temporally. So we'll see what that shows, too.
Great. Thank you very much.
Terrific.